Good morning. Let's get started. Our speaker today is Dr. Donald Tashkin. He's going to talk to us on rethinking approach to COPD management. Our program is underwritten by an educational grant through Sanovian. A disclosure statement has been signed and is on file in the Graduate Medical Education Office. Dr. Tashkin is Emeritus Professor of Medicine in the Division of Pulmonary and Critical Care Medicine, Department of Medicine at the David Geffen School of Medicine at UCLA. He's also Professor of Medicine at the UCLA School of Medicine. After receiving his MD from the University of Penn School of Medicine, Dr. Tashkin completed his residency in internal medicine at the Veteran Affairs Hospital in Philadelphia, and his academic fellowship in chest medicine and pulmonary physiology at the UCLA School of Medicine. His extensive list of professional activities include a member of the Data Safety and Monitoring Board for the Asthma Clinical Research Network, NHLBI and IH, and an invited reviewer for the NHLBI and IH, and World Health Organization report, the Global Strategy for the Diagnosis, Management, and Prevention of COPD, the Global Obstructive Lung Disease Panel. He's a guest editor for such publications as the New England Journal of Medicine and the Journal of COPD, and is the member of the editorial board for Respiratory Research, Chest, and Creating Optimism in Managing Pulmonary Disease e-newsletter. His skills as an accomplished author has produced nearly 500 articles appearing in leading peer-reviewed journals, and he has presented hundreds of presentations both nationally and internationally. Please welcome Dr. Tashkin.
Thank you very much. Well, it's a pleasure to be here. So I'm going to be talking about COPD this morning. This is actually a promotional non-CME program that's sponsored by Sanovian, and I am being compensated for making the presentation. See if this clicker works. And so much for my disclosures. So we're going to be talking about a very important disease. COPD is the third leading cause of death in the U.S. It's the second leading cause of disability due to any medical illness. There are a lot of, unfortunately, there are a lot of problems in terms of the underdiagnosis of COPD, its undertreatment, and problems with poor adherence, et cetera. This is, of course, true for all chronic diseases. It does pose an enormous burden on our healthcare system, as we'll see, of course, also on, obviously, the patients who are unfortunate enough to have the disease. So there are several national and international guidelines, evidence-based guidelines that make recommendations regarding the diagnosis and management of COPD. Probably the most widely cited of these guidelines are the GOLD guidelines that stand for Global Initiative for Obstructive Lung Disease. They were first published in 2001. They've been updated practically every year. The latest update has occurred this year. And the GOLD guidelines actually make recommendations concerning not only the management of COPD in general, both non-pharmacologic and pharmacologic measures, but specifically the classes of drugs that would be appropriate for initiating pharmacotherapy in patients with newly diagnosed COPD, and we'll discuss those briefly a little bit later. Now, the problem with the GOLD guidelines is that the recommendations actually pertain to the drugs, the molecules, and not necessarily to the devices that are used to deliver them. Most of the drugs that we use in COPD are aerosolized, and so as important as the molecules, as the drugs themselves, is the device delivering the drugs. If the device is not used effectively, the drugs are not delivered effectively to the lungs. So, and then we'll close with a discussion of, or a presentation of some of the data supporting the recommendation or supporting the approval of a particular nebulized preparation for the management of COPD. So the burden. So The prevalence of COPD, well, actually about, national statistics indicate that about 12 million Americans have been diagnosed with COPD, but we believe that there are twice as many who actually have the disease. It's based on surveys that are carried out periodically in the U.S. in which participants undergo a variety of tests, including spirometry. And it turns out that over half of those with spirometric evidence consistent with COPD and were never told by their doctor they had COPD. So probably about 24 million. Now, unfortunately, by the time the disease is diagnosed, the disease is more or less far advanced. So about half the patients with newly diagnosed COPD have lost up to half the lung function already, and another third, or close to a third, have lost more than half of their lung function. So actually, the average age of someone who's been diagnosed with COPD is probably somewhere in their 50s, but probably the disease is initiated not long after the smoking habit is adopted in teenage life. But it's a very slowly progressive disease, and it takes a while for the lung function to be impaired to the extent that you can detect it spirometrically. So probably 35 years of age is about the youngest age at which you make a diagnosis of COPD. But unfortunately, most patients who have the disease are not diagnosed until they're older and they're middle age. But once they are diagnosed, they could actually, it could lead to fatality. It's the third leading cause of death in the world, but patients can live for a long time after the diagnosis is made, 10 or 20 years. And during that time, the disease is slowly progressing, and so patients then become disabled by it and eventually die of either respiratory failure or of some comorbid condition that is associated with COPD. So therefore, patients, as they become disabled, become a burden on the caregivers and on our healthcare system. So now, COPD is an inflammatory disease. A lot of diseases have inflammation as their underlying basis. And in COPD, the inflammatory cells are primarily neutrophils, alveolar macrophages. These are the cells that are most populous that reside in the lung. And when they're stimulated, they release a variety of tissue-damaging enzymes, cytokines, and chemokines that cause the damage that produces COPD. Inflammatory thickened airway wall, increased mucus secretion that occludes the airways, and destruction of the elastic framework of the lung, producing holes in the lung or emphysema. In addition, these cytokines and chemokines spill over from the lung into the systemic circulation and affect extrapulmonary tissue, such as the heart, causing ischemic heart disease, or blood vessels causing hypertension, or the bone causing osteoporosis, skeletal muscle causing skeletal muscle weakness, in which actually results, partly contributes to the exercise limitation of patients with COPD. The brain, and arguably predisposing to anxiety and depression, which are common comorbid conditions in COPD. So there are a lot of comorbidities. So when you treat patients with COPD, you're not treating just the airflow obstruction, but the whole patient who has, most patients have more than one, at least one or more comorbid conditions. Cost of COPD is about $50 billion. So that was the cost of Katrina. So it's like having a Katrina every year. So the $50 billion, the cost will probably go up as the population ages and the prevalence may increase. So in this slide, it's a little difficult graph, and it actually illustrates in the orange the trajectory of hospitalizations due to COPD, and you see there's a slight upward tick here, whereas hospitalizations due to other diseases like congestive heart failure or acute MI are going down, because we've made advances in the management of cardiovascular diseases so that actually patients can live longer, they won't die of these diseases, and more likely then have a greater opportunity to develop an exacerbation of COPD that leads to hospitalization. Hospitals are now incentivized to make sure that when patients leave the hospital after having been admitted for an exacerbation of COPD, that they're properly educated about the need to take their medications regularly. We know that non-adherence is a big problem in medicine. Also, that their ability to use the devices that deliver the medication, these inhaler devices, is appropriate. And if it's not, even after instruction, then one should consider nebulized therapy. We'll discuss more about this later as a means of effective delivery of the drugs to the lower respiratory tract. Now, why are hospitals incentivized to do this? COPD, about 20% of patients with COPD after leaving the hospital, after having been discharged after an admission for an exacerbation of COPD, return within 30 days. Not always with COPD, sometimes with heart attack or heart failure or some other condition, but nonetheless, the hospitals are penalized if the patients return within 30 days. So hospitals are developing, more and more hospitals are developing strategies in order to minimize these readmissions. Now, I might say that, let's define exacerbations. COPD is associated with an accelerated rate of loss of lung function over time. And it leads to the symptoms. The most common symptom is shortness of breath with exertion, cough, and sputum. Over time, patients also develop an acute worsening of their symptoms of COPD, more shortness of breath, cough, sputum, often purulent sputum, often but not always due to infection. They go to see their physician, who then prescribes additional medication, often a short course of oral corticosteroids or antibiotics, and that's how we define an exacerbation. So there are about 14 million visits, COPD visits to physicians a year in the U.S., many of them due for exacerbations. There are about 1.7 million visits to the ER for exacerbations of COPD every year. Patients are often discharged prematurely from the ER. They come back within a few days. They're eventually hospitalized. 700,000 hospitalizations for COPD every year. So if you have to be hospitalized for an exacerbation, it's bad news. There used to be a higher in-hospital mortality, but with the advent of non-invasive ventilation, it's less, maybe about 2%. It used to be as high as 8% or higher. But once the patient leaves the hospital, the patient is also at risk of subsequent exacerbation, including a subsequent hospitalized exacerbation, probably about 6-fold increased risk of having to be readmitted at some point, and 30% are dead in a year. So a very important goal of the management of COPD is to prevent or reduce these exacerbations. So, in order to make a diagnosis of COPD, first you have to suspect that the patient has the disease, and as I already mentioned, it's markedly underdiagnosed. The reason is that patients aren't really aware that they have symptoms of underlying disease. As I mentioned, shortness of breath with exertion is the most common cause, most common symptom of COPD, the cardinal symptom of COPD. So what patients do is simply modify their lifestyle when they can't perform physical activities because of breathlessness as they grow older, attributing this problem to just aging or becoming less fit or gaining weight or what have you. They don't realize that there's a problem. They don't report the problem to the physician, who then doesn't suspect the patient might have COPD. Even if the physician does suspect it, in order to confirm the diagnosis, you have to do spirometry. And spirometry is markedly underutilized. So if you did spirometry, you would find consistent with COPD is airflow obstruction that persists even after a bronchodilator. Operationally, we define airflow obstruction as a reduced ratio of the forced expired volume in 1 second to the forced vital capacity. That's less than 70%. That indicates airflow obstruction. If you have airflow obstruction, then you should give a bronchodilator, 3 puffs of albuterol, repeat this spirometry within 15 minutes or so. And if the FEV1 FVC ratio remains less than 70%, that is, the airflow obstruction persists, that's consistent with COPD. If it normalizes, goes above 70%, then the patient more likely has asthma. The problem is that there are some patients with asthma who develop, because of persistent allergic inflammation, may develop airway wall remodeling and also have persistent airflow obstruction. So there may be some diagnostic confusion differentiating between asthma and COPD. And to make matters worse, more complicated, there is an overlap syndrome between asthma and COPD. So the patients with features of both, maybe 10 to 20% of patients with COPD are thought to have this overlap syndrome, which is called ACOS. Now, once you make the diagnosis of COPD, then it's recommended that you classify the severity of the COPD. Now, it used to be fairly simple that you would just do spirometry and base the classification on the FEV1 itself. So if the forced expired volume in 1 second is still in the normal range, even though the ratio is abnormal because the ratio is more sensitive than the FEV1 itself, we call that mild airflow obstruction, or stage 1. If the FEV1 is dipped into the abnormal range, it's less than 80% predicted, but you haven't lost half your lung function yet, that's stage 2 or moderate. If you've lost more than half your lung function, it's severe. If you've lost more than 70% of your lung function, your FEV1, it's very severe. Stages 1, 2, 3, 4, mild, moderate, severe, very severe. Well, it's become evident that there are some patients with relatively mild airflow obstruction that are still quite symptomatic. And so the new classification takes symptoms into account. It also takes exacerbations into account, as we'll see, because exacerbations are such important events that punctuate the course of COPD. And the more exacerbations you have, the greater the rate of progression of the disease, and the greater the risk of subsequent exacerbations, and the greater the risk of death. So all three of these characteristics are then taken into account. And so this is a little bit difficult to see. So we have now, instead of a 1, 2, 3, 4 system, we have an A, B, C, D classification scheme. And so the first thing you need to do is determine, so there are 3 axes. So on the x-axis, there are symptoms, and on the y-axis, the 2 y-axes, on one eye, these are called risk. They're called risk because on this axis here, we have the old stages of spirometric abnormality. So 3 or 4 represents very severe airflow obstruction, FEV1 less than 50% predicted. That increases your risk of an exacerbation, also increases your risk of death. And then on this side, the right side, we have the history of exacerbations. If you have 2 or more exacerbations, you're at markedly increased risk of another one, maybe 6-fold increased risk, or at least 1 hospitalized exacerbation. So those are the 3 axes. So the first thing you need to do is determine how symptomatic your patients are. Well, how much shortness of breath? Well, you may feel that your patients have relative few symptoms, and say another observer may believe that your patients have more symptoms. So you have to be on the same page. What's recommended is to use one of 2 validated respiratory questionnaires. The easier one of the 2 is called the MMRC. It stands for Modified Medical Research Council questionnaire. MMRC was developed in the UK in the 1950s, and since modified, it's very simple. 0, even with strenuous activity, you don't become unduly short of breath. There are very few patients with COPD who are 0. 1, you get out of breath when hurrying on level ground or walking up an incline. Well, there are some patients with COPD who have, some people in this room probably might be a 1. 2, you get out of breath walking with other people the same age, having on level ground, having to slow your pace, not being able to keep up with your peers. So that would be considered significantly more symptoms. 3, you get out of breath walking at your own pace on level ground, having to stop after 100 yards. And 4, too breathless to leave the house. So if it's 2 or more, you're to the right of this vertical line, so you're either a B or a D rather than an A or a C. So the next thing you have to do is determine whether you're below or above the horizontal line, so what your risk category is. So if you had severe airflow obstruction, you'd be above the line. If you had an FEV1 greater than 50% predicted, you'd be below the line. On the other hand, you'd also take into account exacerbations. So if you have 2 or more exacerbations in the last year, or at least one leading to hospitalization, you're above the line. There's increased risk. So you could actually have only moderate airflow obstruction and frequent exacerbations, and you'd be above the line. Or you could have both. That's one of the problems with this classification scheme, and there's a panel of experts called the GOLD panel that's considering possibly modifying this scheme. But in this way, integrating symptoms, lung function, and the history of exacerbations, you could classify your patients as having A, B, C, or D. So is this just an academic exercise? But actually, the utility of this classification is that it provides some guidance as to what medications you might want to start your patients out on who have newly diagnosed COPD. So the recommendations are tied to this ABCD classification. So for example, for A, I know you can't see this very well, but for A, there are not that many patients with A because they're usually not diagnosed. So if you have a few symptoms and you don't have severe airflow obstruction, what's recommended is a short-acting beta agonist like albuterol or short-acting anticholinergic such as ipratropium, or the combination, Combivent, on an as-needed basis. An alternate recommendation is a long-acting agent. The beauty of a long-acting agent is it will last for 12 hours or some that last for 24 hours. And so that if you had a frequent need for a short-acting agent, you would reduce that need, the need for a rescue medication if you used a long-acting agent. So that's an alternate recommendation for A. For B, most of the patients with COPD are classified as B. The next most common category is D. C is an uncommon category because that means few symptoms, but with severe airflow obstruction or frequent exacerbations, and it's unlikely that people in that category will have few symptoms. So it's mostly B or D. So B, moderate airflow obstruction, not severe, with symptoms. For those patients, what's recommended is a long-acting beta agonist, and we'll be talking about one a little later, Brovana, or a long-acting anticholinergic as a first choice. Long-acting anticholinergic used to be only one, tiotropium, and now there are 3 or 4. Or as a second choice, an alternate choice, you could combine them. This is a known long-acting beta agonist. The acronym is LABA, long-acting beta agonist. And for a long-acting anticholinergic or long-acting muscarinic antagonist, the acronym is a LAMA. So you can combine the LABA and LAMA, and there are now 3, there'll probably be 4 or 5 eventually, fixed-dose LABA-LAMA combinations, or you could use a free combination. We'll be talking about Brovana, and we'll show some data on Brovana plus tiotropium a little bit later on, which would be a dual bronchodilator combination, which would be an alternate choice for B. For C and D, once your patient has severe COPD, either C or D, then what's recommended is, for consideration, is adding an inhaled corticosteroid on top of a long-acting inhaled bronchodilator. In the fixed-dose LABA-ICS combination, there are now 3 that are approved for COPD, or a long-acting muscarinic antagonist, a LAMA alone, such as tiotropium. There are others, but but you could use a LABA-LAMA combination as an alternate choice. I mentioned there used to be only 2 LABAs, and now there are more. I think there are about 5. And if you include the nebulized preparations, there are about 6, I think, 5 or 6. So you could use, for example, Brovana, we'll be talking about, plus tiotropium as a LABA-LAMA combination in patients with severe COPD as an alternate choice. So with that, so I'm not too enamored of this slide because I don't think that it's accurate, even though the national attention has shifted to maintenance therapy. It used to be that we would rely mainly on reliever therapy, which would treat patients with short-acting agents to relieve symptoms, and now we realize the benefit of maintenance therapy. We ought to realize the benefit of maintenance therapy. As we'll see in a moment, the large majority of patients with COPD are not treated with maintenance therapy, although they should. So the present is a hope, but it's not the reality. So these are the data. So if you interrogate Medicare and commercial databases, it turns out that close to about two-thirds of patients are not with diagnosed COPD are not prescribed any maintenance therapy, even though the recommendation is that patients with COPD and symptoms should receive maintenance therapy. Majority are not prescribed maintenance therapy. This is a failure of modern medicine. It's a sad commentary on modern medicine. Even worse than that is that patients who are hospitalized with an exacerbation of COPD. So, I mean, what could be worse? You're hospitalized because the disease has gotten so worse you couldn't manage it on an outpatient basis. When these patients leave the hospital, what percentage are actually prescribed a maintenance therapy when they leave the hospital? When they most need it, 20%. So we need to do a better job. We need to educate ourselves, physicians, about and allied health professionals about the need for better discharge planning, making sure that the patients are prescribed maintenance medications so to reduce the readmission rate and actually to improve their well-being, and also to make sure that they know how to use the inhaler that's prescribed, and if they can't use the handheld inhaler, then consideration should be given to nebulized therapy, which doesn't require any special technique for inhaling the medication. So here is some data from a study in which patients were very carefully monitored before and after an exacerbation. And you see that exacerbations, actually, the symptoms escalate fairly rapidly, usually within just a few days, maybe 4 or 5 days. Symptoms get worse. Patient sees the provider, who then prescribes medication. And in this case, the patients were followed for about a month. And there is an improvement. It's not abrupt, but there is generally an improvement within the first few days or so. But there are some patients actually who don't achieve their pre-exacerbation status until a month or so. And some never actually do achieve the level of symptomatology and the level of lung function that existed prior to the exacerbation. And it's not known exactly why, but one possibility is that the patients who don't return to normal are those who don't take their medication. Okay. So I've already mentioned I want to beat a dead horse. So again, so when patients leave the hospital, make sure that, in fact, it's preferable. When we hospitalize patients with an acute exacerbation of COPD, we rely primarily on short-acting agents, usually nebulized preparations, usually a combination of albuterol and ipratropium. And then also they're usually given oral corticosteroids. You don't need IV corticosteroids unless an NPO, and antibiotics. And if you think they have an infection, which is very common. So, but before they leave the hospital, they actually ought to be placed on the medication they're going to go home on to make sure they're able to use them properly. And certainly by the time they're ready for discharge, they need to be educated about the need for maintenance medication and make regular use of the maintenance medication. And they also need to be monitored with respect to whether or not they can use the medication properly. As we'll see, there are lots of mistakes that are made with the handheld inhalers that are available. We'll review those in a moment. And I already mentioned this. So the choice. So when you think the patient might be a suitable candidate for a nebulizer, again, it's not only about patient choice, but it's also about whether or not the patient can effectively use the handheld inhalers. I don't want to beat a dead horse by overemphasizing this point. So there are 4 types of devices for delivering aerosolized medication in COPD. So here we have the meter-dose inhaler. The meter-dose inhaler, or MDI, was invented in the 1950s. Actually, I think it was a pharmacist, I don't think it was a physician, whose daughter had asthma. And previously, we were using a hand bulb nebulizer or something of that sort. So this is a major advance. So the MDIs are very compact. They deliver the medication almost immediately, and they're very effective. So the aerosol is generated by a propellant within the system. The problem is that many patients don't use these properly. So what is required, so first of all, when you depress the canister, the medication is in a suspension, usually it's a suspension under pressure. That's why it's called pressurized meter dose inhaler. And then when you depress the canister, you expose the suspension in the dosing chamber to ambient pressure conditions, causing an explosive decompression, which produces the aerosol. That at a high velocity, which impinges on the back of the throat. So most of the medication then is deposited in the back of the throat. The aerosol lasts for a fraction of a second. So unless the timing is exquisite between inhalation and actuation, between actuation and inhalation, the patient won't be getting an effective dose of the medication. So this is a problem. Many patients really cannot master the proper technique for using an MDI. Also, once they do, so what you should do is inhale all the way, exhale fully, then place the MDI in your mouth, and then begin the inhalation a fraction of a second before we depress the canister, and then simultaneously, and slowly inhale, taking about 3 to 5 seconds to inhale fully the total lung capacity and hold your breath for a full 10 seconds. The slower the inhalation, the greater the delivery of the medication to the lower respiratory tract. The faster the inhalation, the more inertial impaction on the back of the throat and the central airways where you don't want the medication. Many patients, even if they are able to navigate in terms of the hand-lung coordination, they inhale too rapidly or they don't hold their breath long enough. You need to hold your breath for a full 10 seconds, as long as you can, in order to allow the finer particles to deposit by gravity, by gravitational sedimentation. Otherwise, they'll be exhaled. So you want to get these particles to the small airways, which are the major peripheral airways, which are the major site of airflow of pathology in COPD. So there are problems with the MDI. Now, the dry powder inhalers obviate the hand-lung coordination issue. So because your breath, your inspiratory force, is what it provides the energy that deaggregates the powder to break the powder up into fine particles. Well, the problem is that if you're elderly and short and you have diminished inspiratory force, if you're in the throes of an exacerbation, you have severe COPD, you're more likely to be hyperinflated, and the diaphragm, instead of having its normal curvature, is flat. And a flat diaphragm is less efficient in generating contractile force, and you may not be able to generate sufficient inspiratory flow to overcome the resistance of the device. That's number one. Number two, in order to de-agglomerate the powder, you have to inhale rapidly and forcibly. Well, that's a recipe for excessive deposition up here and in the central airways. So there are problems with the dry powder and inhalers. And also they require different kinds of manipulation because there are a number of different dry powder inhalers which go by the acronym of DPIs. So then we have the latest kid on the block is the slow mist inhaler, which is the Respimat developed by Boehringer Ingelheim. It's a very slick device, beautifully engineered. So this device, there are only a few medications that are available in this device. So the medication actually is in a solution which is contained within a capsule. So the capsule is inserted into the device, and it's actually coupled to a spring and a knob. You turn the knob and you put tension on the spring, which forces a meter dose of the medication solution up through a capillary tube. It gets trapped beyond a one-way valve. It's a dosing chamber. Push a button which releases tension on the spring, so the mechanical energy stored in the spring is then available to force the medication solution in the dosing chamber through a series of channels issuing from a single orifice. There are two sets of channels at right angles, and the two jets collide, and the kinetic energy of the collision breaks up the medication solution into fine particles, producing a fine mist, which lasts for about a second and a half, as opposed to an MDI, which is a fraction of a second. So hand-lung coordination is not as much of a problem, but it's not completely obviated. You still have to have some coordination between the inhalation and the actuation, which pressing the button. Also, you need a special technique. You need to inhale, exhale fully, and then slowly inhale, total lung capacity, hold your breath for a full 10 seconds, and repeat it. And then there are some manipulation problems, and also loading and priming the devices can be a challenge for some patients. So there are difficulties with all of these handheld devices. So if patients can't master these techniques properly, and that will be evident if they're not deriving any clinical benefit from the medication, then another choice would be, an alternate choice would be a nebulizer. Now, the beauty of a nebulizer is that no special technique is required to inhale the aerosol. Just breathe normally. You don't have to take a deep breath. You don't have to hold your breath for any time. You don't have to expend any special effort to inhale. Just normal tidal breathing. So it's easy for the patient, but the cons are, but it takes longer to deliver the medication. It may take 5 or 10 minutes to nebulize the dose of medication from the solution in the nebulizer. And then also somebody has to set up the nebulizer, attach it to the compressor, and then it should be cleaned regularly. But that could be done by the caregiver, not necessarily by the patient. As far as the patient is concerned, it's a breeze. It's easy. You just breathe normally, and then the medication gets to the lungs. Now, one of the other, a con would be that it takes 5 or 10 minutes to deliver the medication. Well, if your breathing rate is, let's say, 16 a minute, and say it takes 10 minutes, so that's 160 breaths. Well, you have 160 times opportunity for the medication to be delivered to the lung. But with an MDI or a DPI, you just have one or two shots. So you're more likely to deliver the medication to the lungs effectively with a nebulizer on average. Also, the nebulizers require compressors that could be bulky, but there are now handheld compressors that are battery operated and more portable. Okay, so now we're going to switching gears and discussing a particular nebulized preparation, a long-acting beta agonist that is approved for the maintenance treatment of COPD, and it's called Brovana, which is the trade name for R-formoterol. R-formoterol is a single isomer of formoterol, which is an old drug. It's a long-acting beta agonist. It lasts for at least 12 hours, and it has a rapid onset of action. Now, a very important warning or safety consideration, LABA monotherapy is a no-no in asthma because of evidence that another member of that class called salmeterol was found in asthma to increase the deaths due to asthma fourfold. So in a 6-month trial with salmeterol, it was carried out many years ago, those who were assigned to salmeterol compared to placebo had a fourfold increase in their death rate due to asthma. But there's no evidence that long-acting beta agonists increase mortality due to COPD or increase the risk of hospitalized exacerbations due to COPD. So this is indicated in COPD. You have to make sure your patient does not have asthma. So I think that the text on this slide is quite obvious. That obviously you give a long-acting beta, you hope that long-acting beta agonist will relieve the symptoms of COPD. So the major goals of the management of COPD are to relieve symptoms: shortness of breath, there's wheeze, chest tightness, etc. And there is evidence that a drug like Brovana does do this, as you would expect. Now, all beta agonists, and this is a beta agonist, have potential cardiovascular side effects. the increased heart rate. They could prolong the QTC interval and predispose to arrhythmias. They could predispose to angina in patients with underlying ischemic coronary artery disease. And so you have to be cautious in administering any long-acting beta-agonists, not just Brovana, to a patient with underlying cardiovascular disease. Doesn't mean they're not contraindicated. It's just that you have to monitor the patient carefully. So the dose is 15, it only comes in one dose, 15 micrograms in a 2 ml, this is a 2 ml solution, and single dose vial dumped into the nebulizer and then nebulized twice a day. The patient only has to breathe normally until all the medication solution has been delivered. Now, what are the data? We'll go briefly over this. The data that supported the FDA approval of this drug for the management of COPD. You know, in order to get any new drug approved, you go through a very complicated drug development process. There are phase 1 studies that to prove safety, phase 2 studies determine the appropriate dose, and phase 3 studies are larger, multi-center, placebo-controlled, double-blind trials. So that's what this was. So in order to get into the trial, patients had to have COPD. They couldn't have asthma. They had to have actually moderately severe to very severe COPD. So their FEV1 had to be less than 65, equal to or less than 65% of predicted. As we'll see, on the average, it was somewhere in the about 40% of predicted range. If they were taking a LABA ICS, about 20% were, so long-acting beta-agonists and inhaled corticosteroid fixed-dose combinations, there were 3 that are available for COPD. They had to stop that, and then they were placed on a bioequivalent dose of the steroid. So, for example, if they were in Symbicort, they would be placed on Pulmicort, or if they were in Advair, they would be placed on Flovent. And then they were given albuterol. If they had been on tiotropium, they had to stop that, and they were placed on a short-acting anticholinergic, which is ipratropium, as supplemental medication as needed. And then they were randomized to 5 different dosing, 5 different arms. So and we didn't know what was the ideal dose in terms of safety and efficacy of Brovana. So it was given 15 micrograms twice a day, 25 micrograms twice a day, 50 micrograms once a day. The active comparator was salmeterol, was the first LABA approved, I think, in the 1990s, and placebo. The study lasted 3 months, and the primary endpoint was a degree of bronchodilation. So you have to show that it lasts for 12 hours, a dosing interval, so you had to make sure that at the end of 12 hours there was a significant improvement, and clinically important improvement in the FEV1, around 100 ml or so. And then you also looked at the peak. Your peak is usually higher than the trough. Trough is the lowest value for the FEV1 over the dosing interval. So these were the results. So the green line is Brovana, and the gray line is placebo. And this is a time response curve on the last day of the trial, the 12 weeks. You can clearly see that even when you begin the beginning of the day, the lung function is about at least 100 ml higher than placebo. That's the trough value from the previous dose. And then you see a peak, and then slowly the drug actually partially, not completely, wears off. Some of this is due to just diurnal variability. At the end of the 12 hours, it's still about 100 ml higher than placebo. So it certainly was efficacious in terms of lung function, but patients not really aware of what the FEV1 means. You're more concerned about how they feel. And so what was the evidence that this translated into clinically significant symptomatic benefit? And we see a 37% reduction in need for rescue medication compared to only 2% with the placebo, and a 37% reduction in the use of supplemental ipratropium in those who are using ipratropium. So, and there was, also, COPD is not infrequently causes problems at night. Patients awaken with bronchospasm, cough, maybe wheeze, maybe chest tightness, or they could actually awaken because of hypoxemia. There are a number of reasons why COPD patients may awaken at night. So there was a 19% improvement in the increase in the number of days in which they did not awaken because of symptoms of COPD with Brovana compared to only 9% with placebo. And now, let us say you prescribe this medication for your patient, and the patient doesn't respond as well as you'd like. So the next step could be to add a long-acting anticholinergic, long-acting muscarinic antagonist, a LAMA, on top of Brovana, and in order to achieve additive benefit. So a study was carried out to determine whether if you added tiotropium on top of Brovana, you would achieve additive benefit, additive bronchodilation, without any increase in side effects. That was the hypothesis. And so patients who entered the study had similar baseline characteristics to those who entered the pivotal trials. And here we see the green line is Brovana, and we see during the day, so that it reaches a peak, and then there's a gradual partial wearing off, and then there's another dose that reaches another peak, and so forth. This is by tiotropium. It takes longer for it to reach a peak. It's slower onset of action. During the latter part of the day, because it's longer acting, more bronchodilation than with Brovana, but over the nighttime, there's more bronchodilation with the second dose of Brovana compared to tiotropium. But look at the message here is the additive effect. Look at the blue line. There's about 100 ml further improvement in lung function with the practically a doubling when you add the Brovana on the tiotropium on top of Brovana. So that would be a use, and without the penalty of any increased side effects. So that's a useful strategy that could be adopted if patients don't respond to single agents. So a lot of attention is paid to safety in drug development. No matter how efficacious a drug is, it would not be useful if it were not safe. As I mentioned before, the major concern with beta agonists are potential effects on the heart. So a lot of attention was then paid to cardiovascular adverse events. So the serious cardiovascular events would be an MI or life-threatening arrhythmia. And we see that there was no difference between Brovana and placebo. This is true for ischemic events, for all cardiovascular events, or arrhythmic events. So from a cardiovascular standpoint, within the context of this clinical trial, it appeared to be safe. But a word of caution, in order to get into the trial, you could not have a recent MI or severe heart failure or a significant arrhythmia. So you still have to be cautious in your patients who have significant underlying cardiovascular disease. Other adverse events. So a lot of attention is paid to adverse events. When an adverse event is anything the patient complains of out of the ordinary that bothers the patient after starting the treatment. They're called treatment emergent adverse events. So if you stub your toe and it hurts and you complain to your physician, he's the investigator, he has to record it and communicate it to the sponsor, who then communicates it to the FDA. That's an adverse event. Doesn't necessarily imply causality. So generally, you can have an infinite list of adverse events, and usually for reasons of economy, you generally limit to those that occur in only, say, 2 or 3% of patients in any treatment arm, in which there is an imbalance in favor of placebo, that there's a higher percentage of events occurring with the active drug than placebo. It's a little bit of a bias because you don't look at those that occur more often with placebo than with the active drug. So you can see here, pain, chest pain, back pain, diarrhea, sinusitis. There's an imbalance. There's a small imbalance. Now, could that be due to the drug or not? You can't tell. But it's as I said, not necessarily imply cause and effect. Okay, so now, because of the findings in the SMART study, salmeterol aerosol research trial that showed the fourfold increase in asthma-related deaths with salmeterol, the FDA asked the Sanovian to do a similar study with Brovana and COPD, the endpoint being mortality due to COPD, or actually all-cause mortality, or hospitalized exacerbations. It was a 52-week study, and it did not show any increase in mortality or hospitalized exacerbations. So I just want to end with a few other safety issues. Paradoxical bronchospasm. So if you give a bronchodilator, aerosolized bronchodilators, a very small minority of patients may develop bronchospasm. Paradoxically, because you think bronchodilators cause bronchodilation, open up the airways. But presumably this is due to stimulation of irritant receptors in the airway, leading to reflex bronchoconstriction, which is not adequately counteracted by the pharmacologic bronchodilator properties of the bronchodilator. If that occurs, unfortunately, you can't use aerosolized medication. It can occur with any aerosol, not necessarily Brovana. It could be an MDI or DPI or what have you. So also, not I think mentioned here, sometimes local anaphylaxis occurs if you're allergic to any of the components in the drug system. You can develop a glottic closure, et cetera. It could be quite serious. It happens very, very rarely with any of these preparations. More likely with the dry powder inhaler, because the carrier is usually lactose, which is a complex milk-based polysaccharide, and it can be contaminated by milk protein. If you're allergic to milk protein, you can develop the local anaphylaxis. I already mentioned the potential cardiovascular problems. I don't think, does anybody here prescribe monoamine oxidase inhibitors any longer? I don't think so. Even tricyclic antidepressants have been replaced by newer antidepressants. But these drugs actually can either inhibit the breakdown of catecholamines or inhibit the reuptake of catecholamines into the nerve endings. And if you're on one of these and you're on any beta agonist, it could increase prolong the time that the beta agonist is in the circulation. That's absorbed into the bloodstream. Okay, so I already mentioned the black box warning. I won't repeat that. And finally, this Brovana is so it's interesting that nebulized medications are uniquely covered under Medicare Part B. So if you're Medicare age, you can get these, you have to pay 20% copay. If you have a supplemental insurance, you don't have to pay anything. And it's also covered by a number of managed care plans. And lastly, there is a very useful support system for patients. They can call a hotline and get answered within 30 seconds with a real voice. That's unusual in the modern day society. And then they can receive information about where Brovana could be dispensed, a pharmacy that's near them, any information about reimbursement. And lastly, so twice a day for 30 days, so you need 60 vials. That's how it's packaged. If you're in the hospital, you don't need as many, so you get 30 vials. And hopefully you won't have to be in the hospital, though, for 15 days. So I want to thank you for your attention, and I'd be happy to answer any questions you might have, either about COPD in general or about Brovana specifically. Thank you. Okay. So is anybody going to break the ice? You need an ice pick. I'm sure you see a lot of patients with COPD here. Is Oklahoma have a high prevalence of smoking compared to other states? So you should see a fair amount of COPD. It's a smoking-related disease. There are some non-smokers who develop it as well. Air pollution, secondhand smoke, occupational exposure, et cetera. Questions? Well, yes?
Is there any head-to-head or
Yeah, the only one that it's not been compared with the other. There's one other nebulized LABA, and it's not been compared with that. But Servant, salmeterol, is a LABA, the first LABA, and that was included in the pivotal trials, and it was equivalent in efficacy to salmeterol. But patients had to demonstrate they could use the discus inhaler properly in order to get into the trial. Question. Any others? Well, thank you very much. Thank you.